And so what we're going to do is start off with the key priorities for delivering innovation to support the NHS England's personalised medicine strategy. So Anne Daly, you were the rapporteur, or are the rapporteur, and Phil, you were the chair. So I'll ask you to give a report, and Phil then if you want to add anything, and then anybody else from the group, and then we take questions.
Okay. So a quick summary. Well, first of all, Phil was the chair, and he'll chip in if I get anything wrong or he has anything else to say. So what Phil did to begin with was he got the NHS England strategy for personalised medicine. He downloaded that, this pyramid. You won't be able to read this, but you can find it online very easily. This has come from Bruce Keogh and appeared in 2015. So there are, the flip chart has got the 5, what it's supposed to achieve. First, at the bottom of the pyramid, though, we've got 4 points. We're seeking greater efficiency from streamlined care programs, earlier and more precise diagnosis and treatment, fewer and less complicated surgical interventions, and fewer patients getting cancer and other diseases. So I think those would be aims of any health care organisation, really, and the other information in the pyramid, I think, is more precise on the personalised medicine front. Before I go through what we discussed, we thought the title was quite complex in that it is about delivering innovation to support the NHS strategy for personalised medicine rather than actual delivery of the strategy. These two things are probably slightly different. Couple of points emerged. One was the importance of the patient viewpoint. And there was some concern that patients mightn't understand personalised medicine very well, but we thought overall that the concept of personalised medicine could be got across to the patient, and that was possibly not as difficult as training the staff who would actually be delivering the health care. So our view was that patients will be able to understand and that they are keen to be involved in this. One negative point was made about the possibility that patients having a lot of information about genetic and other tests might lead to potential for overtreatment. It was suggested that that may be happening in the US, where direct-to-patient testing is happening. We were also told in the group about some examples of direct-to-patient testing that's being requested in the UK, but it's not possible to offer because companies generally offering these tests in the UK require the intervention of a clinician. But patients are paying for these tests in some cases to be provided, especially patients at hospitals such as the Royal Marsden. The need for two-way communication and a change in any kind of remaining gatekeeper culture within the NHS, where the clinician is the gatekeeper, was needed. And we did have some discussion about whether patients should be responsible for looking after their genomic data, or whether that was something that the hospital or the NHS should have control over. And I don't think we reached a clear conclusion on that, actually. Briefly, we discussed Scotland. We didn't really get very far on that, except concluding that personalised medicine implementation had probably gone a bit faster in Scotland. That there was a lot of concern about electronic integration between systems, but perhaps that was misplaced, and that maybe high-level electronic integration wasn't that important. So how do we deliver innovation? There's the problem about picking winners. You need to sort of back a few projects and then some will come out. But should the NHS be doing innovation at all was raised. Is that the role of the NHS? I think possibly we need to distinguish between R&D and innovation, which are slightly different. I think most people in the group agreed that. It was felt there was a general suspicion of entrepreneurship within the NHS, although that may be changing slowly. I think we agreed it has already probably happened in the higher education sector through necessity, but possibly there's still remnants of it in the NHS, but that there is change. And things like staff mobility, where NHS staff are moving into industry and moving back again in some cases. There's also examples, at least in some trusts and hospitals, of mentoring schemes to encourage innovation. And there are some days where there are meetings organised by trusts involving exchange between NHS and outside experts. Some of this is regional. I think there's a number of different schemes operating depending on where you are in the country. It's always important that impact and value can be demonstrated, and that's not always easy to do. And it was pointed out that there is funding available for innovation essentially from outside the NHS, especially from the EU, as long as we're staying in the EU. Some of that may need matching funds, but it isn't necessarily taking money away from patient care if you're using these sorts of funds for innovation, as they're intended to support innovation. We spent a bit of time at the end talking about what we could learn from the 100,000 Genomes project, which appears to have been generally successful and is probably getting close to completion now. So we thought the 100,000 Genomes had a clear leadership. It had clear rules, good communication, and some of this comes from having a large budget. Apparently, it's been quite burdensome on staff in the NHS, the delivery of this, but staff have generally got involved because they don't want to be left behind. It adds to their workload, but they seem reasonably convinced that it's a worthwhile project and that they should engage, probably for some of these reasons that we've listed. So further innovation within the NHS may stem from the 100,000 Genomes project. Even if the sort of money that has funded the 100,000 Genomes project is not immediately available. We concluded by pointing out that learning from failure when driving innovation is going to be important, and that you shouldn't expect every project to be successful, and that other institutions, such as the Army, who have post-mortems about various events, so doing something similar in the NHS might be worthwhile in terms of driving innovation.
So hi everyone, so my name is Pablo, I'm one of the National Medical Directors, Clinical Fellow at NHS Improvement. I also have a keen interest in innovation, entrepreneurship and personalized medicine. And I've been helping to sort of take some notes and then summarize some of the discussions that we've been having in our group, which was chaired by Tony Young. So just to clarify, in terms of the question that we had, we looked at this as a 3-point question. So how do we develop one high-quality system from an innovation adoption perspective, where innovation is taken up across the NHS, and the third point being without creating or exacerbating inequalities. And I'm just going to summarize the discussions in that order. So looking at it from what is it a high-quality system from my point of view? So we tried to think about it from an innovation perspective. So we would want to have a system where you can optimize the speed of adoption. You want to have a system that can optimize personalization. And you want to, at the same time, being able to optimize safety and risk. So you're not actually putting patients at risk by accelerating adoption. You want to have a system where there's sort of adequate patient and clinician engagement. And you want a system that is agile and able to actually adapt to changing circumstances. And most importantly, you want a system which is able to learn from itself, learn from its mistakes, and then feed that back into the system so that we don't keep repeating the same mistakes and the same problems over and over. And sort of looking at that, we've explored a few examples of where adoption has happened quickly and perhaps the reasons why that would have happened. We've talked about the HRSUB test, we've talked about the CK test as being two examples where, for very particular reasons, the adoption happened fairly quickly, but we sort of were quick to realize that actually doesn't happen across the board, and most of the time adoption is quite slow. Now, looking at the issue of actually the system level adopting innovation within the NHS, we discussed a little bit about the barriers to adoption and then about the potential solutions to those barriers. So when we think about barriers to adoption, so one of the important challenges we notice in the NHS is actually, if you look at the number of people working in the NHS, 1.7 million, and then actually the number of people who have anything to do with innovation, spreading, adopting innovation, or helping to empower that, actually the percentage is quite small. So that's one of the things that sort of came across. The second point was, how do we convey clearly to all the different stakeholders what are the benefits to them of a specific innovation, and whether it's patients, whether it's professionals, clinicians, managers. So just to highlight a few examples from a patient perspective, I mean, there has been a sort of NHS-led initiative where sort of wanted to encourage GP practices to open up the patient record to patients, allow them to book appointments online, and allow them to sort of request repeat prescriptions. But actually, the actual uptake of that after 3 years was only 10% of patients in 80% of sort of GP practices. So actually, the question was whether that was conveying, how was that benefit conveyed to the patient? Did the patient actually understand what was the need for them? And if they did, then why didn't adoption happen quicker? Then there's the issue of healthcare professionals, and as clinicians, we often want to see a randomized controlled trial proving clear benefit before we even consider taking up a new innovation. So the question is, how can we create a partnership working across the different sectors to perhaps change that culture and start looking at, is there a way we could actually look at incremental learning and perhaps pick an earlier point in the innovation where we could start testing and using things before we have sort of RCT level evidence. And obviously we've got managers who have their own pressures in terms of running their own systems. Then there was a question about whether a one-size-fits-all approach works in the NHS, or whether actually different people will have different needs. And and just coming back to the previous example, actually pushing all GP practices to make something available to all patients, where actually not all patients are looking for that. Is that the right approach? And is perhaps that one of the reasons why we haven't been able to sort of diffuse innovation quicker? Then in terms of on a sort of looking at more on from a solutions lens, what can we do to address some of these challenges? And these are just some of the ones that we thought we'd highlight. So one is, there's an issue about going from a supply-based system versus a demand-based. So actually, rather than looking at, we have all these innovations, let's see how we can bring them into the system, why not focusing on, actually, let's look at what are the problems in the system. Let's identify, perhaps at a population level, for example, on an STP level, or perhaps on a national level, which might be less likely to work. What are the key priorities? What are the areas that need to be addressed? And then put those, and then allow innovators and industry and entrepreneurs to actually address those issues, rather than saying, oh, here's a solution, let's find the problem. So there's a bit of that situation happening in the NHS, and that's something that we've spoken about. On that point, we've also talked about, actually, if you do create that system, how do you filter ideas? How do you filter solutions? Do you have to have a national sort of funnel to decide what works, what doesn't? Is it best for that to happen locally? Is it best for selection to happen naturally through individual entrepreneurs, trial and error? So what is the best way to go about that? And then another sort of key point that we highlighted was the issue of reinventing the wheel. So we face similar problems across the UK, as they do perhaps in Portugal, Canada, or other countries. And whilst we are trying certain solutions, they might be trying different things, and it might be that even sharing some of that learning, perhaps internationally or even across the UK, not just on what works, but actually what have we tried and didn't work, so someone else won't go and try and reinvent that again. that might help optimize and increase the efficiency of creating and sort of diffusing and adopting new innovations. So we've talked a little bit about how we could do that, whether it's within an STP, across organizations, etc. And then just bringing us to the point of who do we want to emphasize? And that is the people, actually. We want to have a commitment from the top that will, at the top of the NHS, that will support individuals to develop the solutions. But then those individuals, those champions who have solutions, they need to be brought together to create a bit of a clustering effect where some of the perhaps more high-risk decisions are easier to take between groups of individuals rather on your own. And through that network effect, hopefully more and more innovations will be coming out. And then once we have that, we have to create a system to incentivize, not on a system level, but on an individual level through a sort of carrot and stick approach so that the innovations can be pushed forward. And finally, we need to have that sort of feedback loop to see what worked and what didn't. And just to finally, just in the third point in terms of the inequality situation. So this seems to be a challenge in the sense that we're here to talk about personalized medicine. And if we think about personalization, we think about how do we make medicine best for an individual? How can we optimize treatment for that one person? And by virtue that would mean that actually the treatment that you have perhaps is different from yourself, or yourself. Whatever works best for you might not work best for you. So when we're thinking along those terms, actually how does inequality fit in that? The second challenge is actually, if you're thinking about creating new solutions, new innovations, and actually you have a context of limited resources, and perhaps, say, Cornwall has different priorities from Manchester, from Cambridge, etc., and there is each start focusing on a few priorities, in a short term, that might create a little bit of an inequality, but then on the medium to long term, if you can diffuse those solutions across the UK, then actually you overcome that inequality. So rather than calling the question or stating in the question without creating inequalities, we thought perhaps we should say whilst we are working to address the inequalities. So inequality could be a temporary situation which eventually will lead to perhaps better care for everyone. But we might have to start with a slightly unequal position to be able to get there.
Hopefully you can catch this. So we did a double act just like everybody else did. What we decided to write on was the analogy of a toolbox, which I believe was used earlier. I wasn't here, but the idea being that everything that we put in the toolbox would enable innovation to actually happen and would encourage, or it would help innovation to happen. It would encourage entrepreneurs to get started, to invest, and to attract investment by smoothing the way towards the end objective, which was a customer with a known need and money. And that's what we alighted on. And the process we'll go through in a second, if that's okay. Thank you very much.
We treated this as a generic problem. And as Paul said, we've come up with a 8-point toolbox, which was generated from looking at 5 issues and requirements. People had discussed about the need for access to the NHS, access to the right people, for the innovation, for the introduction, for the adoption. People were concerned about the problem identification and being able to connect to the real problem that the NHS and local authorities have for what really are the crucial health issues. There was a discussion in and around whose budget is it and who's impacted by the change, and there was some discussion about how do we motivate people to do this. How do we need to understand how to motivate the switch in technology? We need to be able to motivate the behavioural change. And I don't think anybody has rolled in front of me, if you like, a psychological assessment of NHS behaviour, because doctors are different than the rest of the population. There doesn't seem to be a market pull. It is taxpayers, but who really are the customers here? Because it might be it's your budget, but then the cash release saving is only within you and within your year. It's very difficult to see where the pull is for adoption. And there was another item which nobody's mentioned so far. Please recall, you need a sufficient population, a sufficiently big locale to make the innovation workable and investable. It's no use it only being useful for 10 people. It's unlikely to get the investment. So looking at those issues and requirements, we came up with a, as I say, an 8-point toolbox. The first really big idea is some common standards and data that is absolutely necessary to be able to stimulate this innovation. There is data on multi-morbidity in aging, whether it be genomics, phenotypic, drug, pathological imaging, but it all needs linking, and it needs to be made available to both internal entrepreneurs inside the NHS and external companies, knowing where it is, how to access it, what quality is. So that was the first element of the toolbox. Second element of the toolbox was the NHS test beds. But please, let's not have them piecemeal. Let's have some coherent ability for companies and entrepreneurs to access samples, to access patients. And that's, I think, a real issue for the smaller end of the SMEs. It's okay for the Glaxos of this world. The third item of the toolbox was some sort of, well, the Clinical Entrepreneurs Group is a good example of this, some sort of network or some introductory directory of experts that are so that people find it easy to get at the right people. It's fine to know how to talk to Alistair Breckenridge or something, right? But actually what you want to be able to do is to talk to the clinicians at the coalface who never have the time to actually be able to do this. And I think more effort needs to be done with KTN, with this network that Munir runs, with the Royal Colleges, etc., to make sure that we're all linked up with this Clinical Entrepreneurs Group. The fourth item of the toolbox was having some platform standardization so that we can build coherent sets of solutions that can be bundled together and as part of a principle and philosophy of doing something at scale. So I think we were all looking forward to a much more mature service provider and solution provider environment in this area. The next item of the toolbox was to incentivize people to actually go for these for this common list of problems. All right, this was one of the issues, but somehow we've got to get people to work on the things that need to be worked on. An idea came up about putting a sort of challenge. I don't know, does anybody know about innocentive challenges? No. Okay, they're challenges where people put down a list of things you'd like to work on, and there's a reward if you produce a solution within a certain time. Okay, well, why are we not doing that for some of the big issues? A sort of, I remember in primary care where I am, there was a thing called the Prime Minister's Challenge Fund, where you used to be able to bid for money for transformation. Well, why don't we have a grand entrepreneurial challenge, clinical entrepreneurial challenge, whereby the people, like an open RFP, all right, is another way of looking at it, where there's a fund, there's some sort of administrative and secretarial support for applications for SMEs, and NHS centrally contribute to a part of the prize or a part of the adoption, or commit to, if a solution is made which matches that criterion and matches that cost saving, that it will be adopted or it will be purchased to de-risk the situation for the entrepreneur. But that would be an open competition where first one gets in wins or the first few are adopted. So that was that part of the thing. Clearly there needs to be funding appropriate streams in this toolbox. We need lists of angels, we need lists of grants, we need some sort of database of where you can find money. There was a suggestion to have events of angels, events of experts in hospitals, open workshops, sort of hackathons, if you understand me, to publicise things. There is a downside with that. There are too many events, and you get event overload. But something I think branded in that area, whether it's branded by the the Clinical Enterprise Partnership or branded by Munir's brand or whatever, something needs to be done in that area. Finally, the last part of the toolbox is a small item around governance for publicly funded spin-outs and their use of the catapult process. It seems crazy that we let academics and NHS spin out things without putting in place the support to grow them past the point where they might be acquired by the US. So that they're, to use that phrase, they're catapulted into a bigger scale, and the academics and the clinical doctors are recycled back into their original life. But if you like, very commercial people scale it up beyond there. And there needs to be something around governance and something around better support from the catapults in the toolbox too. There were two orphan items that brought up. One was, they're not in the toolbox, one was why aren't hospitals doing more like universities are to set up campuses or hospitals in other parts of the world? The King's College Shanghai thing was mentioned, where they are actually doing a clinical entrepreneurship program, or are interested in it, I think, aren't they?
They were interested in
Yeah. Universities do that. They set up campuses abroad. Why don't we set up a university college hospital in Malaysia or something? And the other orphan item that came up was something that there's been a rule change about that in the NHS you can commission your own inventions, I believe. If anybody can comment on that for me. But that's it. That was our thing. We came up with 5 issues and 8-point toolbox.